How guide extension catheter saved my day, Dr. Rakesh Jaswal. Yeah.
Today, I'm going to discuss with you the role of guide extension catheter. All the interventional cardiologists who started doing intervention in 90s, they all are aware of the mother and child catheter that we had been using in certain tough situations. And at that point of time, probably we never realized that this extended armamentarium of an interventional cardiologist, this would become so refined and user-friendly that we would be using it very, very frequently, maybe in about 20% of our cases. Another important thing is that with passage of time, over the last 25 years, we have seen that the kind of interventions that we are doing are becoming more and more complex. We are hardly doing class type A lesions now. It's most of the time type B lesion, CTOs, or sometimes, it's a bifurcation, left main. Sometimes you have to do OCT, where the OCT catheter is difficult to negotiate, so you have to take the help of a guide extension catheter and to give selective injection or even for aspiration sometimes. So common uses of guide liner we all know. I'll share with you a very rare situation where guide liner or guide extension catheter, it bailed me out. So we had an 80-year-old patient who presented with recent onset angina, hypertensive, diabetic, no family history. The examination was non-contributory. It was all normal. Echo was normal. And angiogram, as you see, had diffuse calcified LED disease right up to the distal LED, and an OM which was around 80% hostile. That was the only major OM. There is another one which is small and 100% occluded. But the calcified. So we will be doing an rotablation with stenting, and then we will fix the OM also after doing the LED rotablation. So once that decision was taken, 4 days later, the patient was taken up for rotablation. So this is 1.25 millimeter burr, which was, selected specifically because, in diffuse disease, I normally prefer to use, 0.4 ratio of vessel to burr ratio. And as you see, look at the guiding catheter also, it is about 3.0. So after that is decreased a bit, which was expected also because of the diffuse calcified disease. And then we started dilating the lesion with balloon. And at this stage, during the mid part when it was being ballooned, that time the balloon got ruptured. And in an effort to, you can see the guide extension tip somewhere here. And during this effort, what happened was this. We had dissection of the left main going into circumflex, LED, the entire coronary circulation was down. There was hematoma involving the sinus, aortic root. So we were in a terrible situation. We know that the RCA was hardly existing. The patient got sick very quickly. So instead of, going ahead with the intubation or anything, we just started doing some CPR, some intracoronary epinephrine and adrenaline. And then we quickly, took a guideline that we took 4 millimeter into 12 millimeter stent. And after the left main was fixed, just proximal to the bifurcation to the ostium, at this point, you see, this is the guide extension catheter which has been parked inside the stent. The purpose was, we have ended up with this situation earlier, and when I analyzed my case later on, right? And in that case, it even got deformed. So we didn't want to land up with this situation because we had no time. We had to revascularize everything in a very, very quick and effective manner. So just parking the guide extension catheter within this stent in the left vein, it gave you a lot of comfort. And I think the entire time taken after this was around 5, 6, 8 minutes to, uh, and at least there were 20 passages of balloons and stents. So quickly, the entire LED was again dilated with cutting balloon usage, and then 3 stents were quickly deployed to LED, overlapping with the left main stent, right? And was dilated, optimized, and then circumflex was also in bad shape. There was a dissection into the circumflex, compromised flow, and even after we had stented everything in the LED and left main, even at that stage, due to circumflex, we were getting into trouble in the sense that patient was having intermittent bradycardia and hypotension. So we quickly crossed over to the circumflex through the stent, culotte, followed by kissing balloon, and this is before pot. This is before ostial optimization, and then after kissing again pot, and then ostial optimization, and this was the result. So basically, in this situation, you have very little time. So you cannot struggle with the ostial stent, and if you have to fix the ostial stent, because if you do not allow some circulation to go down into the coronary tree, patient doesn't give you time. So it's a warlike situation. You have no option but to fix the ostium first, and then through that stent, struggle, or you cannot allow the guiding catheter to deform that stent. So the best option is to place a guide extension inside the stent, and everything becomes very smooth. So I think we took hardly 6 to 7 minutes to fix up everything and do the bifurcation also. And still, within that time also intermittent, CPR was also being done, and at least thrice he required, intracoronary adrenaline. So that's how it helps you, and it bailed me out by making things too smooth for me. And within 6 minutes of that intervention also, when the patient was taken off, on table itself, he had to be intubated, intra-aortic balloon pump was placed, after we completed the stenting. But still patient was in frag pulmonary edema, the pressure was around 80/50, then he was shifted to ICU, and then, all expected problems, including anemia, sepsis, ischemic ATN, uncontrolled diabetes, thrombocytopenia, everything happened. And fortunately, after working hard for about 10 days, we sent the patient back home with an ejection fraction of 45%. And during the follow-up, the patient had normal ejection fraction, good exercise capacity. Then 3 years later, we did a stress thallium also, which turned out to be negative. The purpose was to persuade him to fix the OM, but since there was no significant ischemia, so patient also didn't agree, and we also didn't want to fix the OM. I think he was doing perfectly fine. The latest follow-up is 4 years later, which is December 2020, and patient is going home. Is doing pretty well, right? So during complex angioplasty with rotablation, high pressure balloon dilatation, there is always risk of inadvertent catheter-induced iatrogenic dissection of left main. The patient crashes quickly in such situation. So maintaining cool nerves and concentration is the key. With such patients, they go very quickly into EMD. So immediately start CPR to generate some pressure, intubate the patient, stent the ostium, advanced guide liner within the stent to facilitate passage of distal stents without distorting the left main ostial stent, and also to facilitate, because you are running short of time, you have to do it in a almost lightning speed. You have to do it. So this gives initial stabilization to perform good quality intervention, and then you can carry on with the rest of the things. So with that, I conclude this case where a relatively rare usage of guide extension catheter saved the day for me, because I was in a terrible situation where any delay or any wrong decision on my part could have killed the patient on table. Thank you very much.
So congratulations, Dr. Rakesh, for a great save and good long-term outcome results, and very well shown guide extension. So couple of things now. That I saw that IBP was used at the end of the procedure, not during the procedure. And still, yeah, so that was very good that the patient did make it despite all that. Maybe you didn't have time to put in IBP during the
time. In fact, the intubation was also simultaneously done. So first thing was to fix the coronary flow.
Right.
It was virtually crashing.
There was you are absolutely right. If you have diagnosed the problem that there was left main nostril dissection, just put a stent inside. I would say, even if the left main is short, and if it is extending into LAD or circumflex and gives distal dissection, also no harm, but get the flow in. That's the first thing. And then you have breathing time to do rest of the things, which is what you did. And then you showed us that instead of struggling with support and all that, if you have a guide liner in place in the left main, then you can push many things inside quickly and swiftly. So I think that was a good demonstration of a very useful technique, which I think we should now also incorporate in our practice, in especially in emergencies, to use, take the help of, and there should be a low threshold. As soon as things are not moving, I think there should be a low threshold to take in a guide extension. So thank you very much, Dr. Rakesh, for that novel idea and demonstration.